Hello, 2025 May Orvis Symposium attendees. My name is Mark Gabot, and I'm excited to present our research on identifying risk factors for postoperative pneumonia in thoracic surgery patients. Postoperative pneumonia is the third most common postoperative complication contributing to significant morbidity, mortality, and increased healthcare costs. Current risk prediction methods often rely on pre-surgical respiratory function tests, which are not routinely ordered for all thoracic surgery patients. As a result, there is a need for a more comprehensive, data-driven approach to identifying at-risk patients. The goal of our study was to develop and validate a predictive model that could identify thoracic surgery patients at risk for postoperative pneumonia. Additionally, we aim to create a risk-based calculator to assist anesthesia providers in clinical decision-making and implement evidence-based recommendations to help reduce the incidence of postoperative pneumonia in high-risk patients. To achieve this, we conducted a secondary analysis of data from the ACS NISQIP database, which is a nationally validated surgical outcomes program examining thoracic surgery cases from 2013 to 2022. We analyzed 82,138 thoracic surgery cases filtered using CPT codes and applied three different statistical methods. First, we performed logistic regression on a refined dataset of 9,014 cases, excluding patients with missing data. Second, we used machine learning, specifically XGBoost, on the full dataset of 82,138 cases, applying tenfold cross-validation to improve predictive performance. Finally, we conducted an expert panel review using the Item Level Content Validity Index, or ICVI, where 18 expert providers rated the relevance of 23 variables in relation to postoperative pneumonia. After excluding incomplete surveys, 12 completed surveys were analyzed, and a separate logistic regression was performed on 81,832 cases based on the 6 expert-selected variables. Each model's performance was assessed using AUC-ROC scores with higher values indicating better predictive accuracy. Our findings revealed key insights. Logistic regression identified 9 significant predictors of postoperative pneumonia with an AUC-ROC score of 0.72, indicating fair classification accuracy. Machine learning, or XGBoost, outperformed logistic regression, achieving an AUC-ROC of 0.75, demonstrating the potential for AI in clinical risk prediction. The expert panel consensus identified 6 key predictors, but logistic regression on these variables yielded an AUC-ROC of 0.6, suggesting lower predictive accuracy. The most critical risk factors identified were sepsis, SIRS, male gender, bleeding disorder, current smoker within 1 year, disseminated cancer, hypoalbuminemia, history of severe COPD, and anemia. Based on these findings, we developed a point-based risk calculator to assist anesthesia practitioners in identifying high-risk patients preoperatively. This research has significant clinical implications for anesthesia and perioperative teams. By implementing this model, we can identify at-risk patients early, optimize modifiable risk factors preoperatively, and tailor anesthesia management plans to reduce the incidence of postoperative pneumonia. For example, targeted prehabilitation programs and perioperative interventions for high-risk patients could improve outcomes and reduce complications. By integrating predictive analytics into clinical practice, we have the opportunity to enhance patient safety, improve surgical outcomes, and decrease healthcare costs. In conclusion, our study provides a novel, data-driven approach to identifying and mitigating the risk of postoperative pneumonia in thoracic surgery patients. Future research should focus on integrating these predictive models into electronic health records to facilitate real-time clinical decision-making at the bedside. Thank you.